My name is Eccrine. We're going to look today at sweat gland tumours, both the clinical features, the microscopic features, and the histopathology. Now, on this list, we're going to start with cylindromas. So, let's have a little look at a cylindroma. These are sometimes known as turban tumours. They typically occur in the scalp. They are usually fairly large, pinkish to purple like this, and may be grouped together like a bunch of grapes. They're often seen in association with trichoepitheliomas. The combination is known as the Bruch-Spiegler syndrome. Generally, they arise in adulthood, and they're much more common in females. The thing about this in the Bruch-Spiegler, it's inherited as an autosomal dominant condition. They're fairly slow growing. They're usually smooth surfaced like this, and as I say, you get clusters like a bunch of grapes. As well as trichoepitheliomas, they can be seen in conjunction with spiradenomas and milia. And it's that combination of spiradenomas, trichoepitheliomas, and milia that you see in the Bruch-Spiegler syndrome. The thing about them is they're benign. Cutting them out is difficult. They often bleed like blazes. But electrosurgery and laser therapy can be used, and very, very rarely do these ever go malignant. Now, here's a quick view of the histopathology. The characteristic feature is this jigsaw puzzle arrangement of blue cells, and they're all surrounded by this stroma, eosinophilic stroma. Let's have a look at some other cases here. Now, have we got a histology? Yeah. Let's have a look at this one. Sorry, a little bit of trouble getting this. There we go. Here again, see these collections of blue cells surrounded by that eosinophilic stroma, like a jigsaw puzzle. Make this a little bit bigger. You often have an outer ring of darker cells like this. It's almost like the sort of palisading that you may get in a basal cell skin cancer, and with the paler cells, some eosinophilic cytoplasm in the center. This is a very characteristic picture, this jigsaw puzzle picture for a cylindroma. Let's see what else we can get on it. Yeah, sometimes it's colloquially said to be blue balls in the dermis when you're looking at this. And that's exactly what it looks like. And you also get some eosinophilic globules within these actual lobules. You may get some ductal differentiation here as well. Just looking to see if there are any ducts, because remember, it's from an eccrine gland. You got this very sclerotic stroma that we spoke about before. You can use some special immunostains. CEA and EMA are often positive. And the main differential diagnosis of this is another blue tumor, a spiradenoma. But we'll come to that in a little bit later. So, in fact, we may just go to it just now. Here's some of the features in the Atlas Muni. Do they have a clinical picture? No. They're basically saying an intradermal nodule up to 2 centimeters, sometimes a linear arrangement, young adults, as against the cylindromas, which are older people. Nodules are tender sometimes painful. It's one of the tender nodules of spiradenoma. Let's see what example they have here. Now, what have we got? Oh, yes. Now again, this certainly looks like blue balls in the dermis, doesn't it? It's another one of the blue tumours. The others can be Merkel cells and basal cell carcinoma. Characteristic feature here, the very sharp circumscription of these. And as he says here, they resemble lymph nodes, or may resemble lymph nodes. Small dark nuclei in the periphery, larger pale nuclei in the center. So again, somewhat similar to the Cylindroma. Let's just bring this up a little bit. See what other information we can get on it. But there's no hyaline sheath surrounding these as there was in the Cylindroma. And they're saying that in addition, tubules, PAS positive hyaline granules and scattered lymphocytes are present. Sometimes the tumor can be mixed with a Cylindroma. There's certainly not that sclerotic stroma that there was in the Cylindroma, is there? And the outer cells aren't quite as dark as it was in the Cylindroma either. So, an eccrine spiradenoma. Not sure that I can tell you much more on that one. Just give me 2 seconds. I'll see if I can get a bit more information for you on this. Yeah, they're saying that multiple lesions can also be found in association with trichoepitheliomas and the cylindromas in the Brooks people, so you can get spiradenomas in that as well. Usually solitary though, and as I say, tender or painful tumor, as against the cylindroma, which is usually multiple. Smooth surface, but then so is a cylindroma. And generally benign, surgical excision curative. Very rarely does malignancy occur. Yeah, they're talking of this dual cell population, polygonal cells, large pale nuclei surrounded by a periphery of darker cells. No pleomorphism, no mitotic activity. Yeah, they're saying may overlap with syndromas, but I think it's the lack of stromal reaction there that would help to point towards a spiradenoma. Interesting, it's S100 positive. Okay, so the next one we'll have a little look at. We might go back and have a look at some of the clinical images that we have here as well. Let's go to this one here. This is probably the commonest eccrine tumor that you're going to see, and that's the Syringoma. And they typically occur in this location, the eyelids. They may vary in size, depending on the season of the year. When it's warm and humid and you're sweating excessively, they're more prominent. And sometimes they even disappear in the winter months. They can get probably double that size, but this is typically how Syringomas will in fact present. And when you look at the histology of a Syringoma, it's typically like this, ducts with small tails of blue cells, sometimes described as tadpoles. This tumor has a propensity, obviously, to form ducts because of its eccrine origin. Let's again have a little look. And see what we've got here for for nice Syringomas. There we go. Now, let's have a look at this one. Very similar picture this to the one we just showed you earlier on. Make this a little bit larger. Again, you can see the multiple ducts that are here. You can see sometimes a crescent shape of blue cells surrounding the duct itself, sometimes tailing off into the tadpole shape. There's sometimes quite a sclerotic stroma. The more sclerotic it is, then the other name that can be given to this is a desmoplastic Syringoma. You can also get a Chondroid Syringoma when you get calcification within this area as well as a degree of metaplasia. But this is the typical feature of a Syringoma. The multiple ducts will give it away, and the little tails of blue cells surrounding the ducts or partially surrounding them or running away from them will also tell you it's a Syringoma. Now, what other ones can we give you a little bit more information on Syringomas? You can get them erupting elsewhere in the body as well. It's not just on the face. I've seen multiple Syringomas erupt on the trunk before as well. And in these circumstances, they're often brown, hyperpigmented small papules when they come up in the trunk in this eruptive variant. They can be removed, by the way, by punch excision, electrosurgery, cryo, laser therapy. Any of these can be formed, or can be done. There's another variant, by the way, of Syringoma called the clear cell Syringoma, and sometimes associated with diabetes. I think there are clear cell variants of virtually every tumor. Let's have a look at another case. Let's look at this one. They've got a clear cell down there. Let's just go and have a look at this in a minute. Sorry, we'll have a look at this variant first, or this example first. Okay, much larger tumor, this one. You can still see all the ducts that are forming here. You can still see these tails of cells. You might misdiagnose that as a infiltrating basal cell skin cancer, but all the ducts would give this away. With a lot of stroma, it would be a desmoplastic Syringoma. Let's have a look at this clear cell variant that they have here. Remember, we said this variant is sometimes associated with diabetes. Need to go into this a little bit more carefully. There's certainly multiple ducts there. You can see all the secretion in them. It's a question of where the clear cells are. Sorry. Well, there's all your ducts anyway. They must be talking of these cells around here as being the clear cells in this variant. Clear cells lining these ducts. Okay. Clear cell variant of Syringoma. Now, what else can we tell you about these? Usually the lumina will contain this eosinophilic material, There shouldn't be any pleomorphism or mitotic activity. You've got the sclerotic stroma in the background. Generally, in a syringoma, you won't get penetration all the way down into the fat tissue. But this kind of, by the way, the clear cell variant that we showed earlier on here, the material within these is glycogen. That's usually the material within most clear cell variants. It doesn't matter what the clear cell variant is. Okay. Now, let's go back to the clinical things. What else did we want to show you? We talked about the desmoplastic variant. This was an example of one here. You know, he presented with this lesion here, and it was quite firm. And I must admit, I thought it was probably going to be a desmoplastic trichoepithelioma. Usually in those, though, you'll see tiny little milia from keratinous cysts within the lesion. Now, you know, this was the lesion when we sort of squeezed it to make it more obvious here. You might also wonder if that's a basal cell skin cancer and infiltrating BCC. This was the dermatoscopy. I'll just make it a little bit bigger. Wasn't terribly helpful here. There certainly weren't any little milium cysts there to make you think it was a trichoepithelioma. The blood vessels, they're linear and a bit serpentine, but they're not sharply focused as you would see in a basal cell skin cancer. I don't think you can get much more out of that dermatoscopy. Let's see if they've got a well, as I say, that was a desmoplastic syringoma. We had another variant, this one here, and this turned out to be a chondroid syringoma. Now again, a pale to light pink nodule. This one wasn't as firm as the other one. This was the dermatoscopy. We're just getting the edge of it there. This is the edge of the lesion here, but I'm not sure I can get much out of that either that would allow me to make any diagnosis of a chondroid syringoma, which is what this was. This is the picture of the chondroid syringoma here, and let's go into this area here and have a look at it. Now, some details on a chondroid syringoma, sometimes known as a mixed tumor. And it's a benign sweat gland tumor with a chondroid matrix. In adults, usually in males, as was the case here, solitary formaldehyde nodule, a benign lesion, and very rarely malignant change may in fact occur in these chondroid syringomas. It's described as being a circumscribed multinodular tumor with a pseudocapsule. So there's this pseudocapsule around the outside of it. Nests of cells with eosinophilic cytoplasm, ducts and glands. There's no pleomorphism, few mitoses. Occasionally you'll get keratocysts in there. There's no great example of keratocysts in this particular one. And bone formation is a rare feature here. So this is the picture that you'll see in a chondroid syringoma. I wonder if we'll have any other images of this. No, they don't seem to have any other variants here that we can see. Ah, here's a Chondroid Syringoma. Let's have a little look. Better example, isn't it? You know, an encapsulated or pseudocapsule around this solitary lesion, multiple ducts, lots of blue cells, and then these pale chondroid-like cells surrounding the lesion. Can we go in a little bit deeper to this? Yeah, that's a better view of it. These are the multiple ducts here, some blue cells surrounding them, and then this chondroid change surrounding the rest of this lesion. Let's see what comments they make here. No. Nothing much we can get out of that. Just a space around the actual tumor. Okay. What other eccrine lesions do we have to have a look at? Let's go back to the clinical. What else do we have? There are just some other examples of multiple syringomas. Here are multiple syringomas occurring around the genitals. Now, again, I'd be hard-pressed to make that diagnosis just looking at these initially. You've got this whitish material within here, but these were eruptive syringomas in this area. There's two other lesions that I want to speak about today. Let's have a little look at this one. This is a nodular hidradenoma. A solitary lesion occurring in the scalp. It sometimes is called a clear cell hidradenoma, a clear cell myoepithelioma. Its major clinical features are that it's seen most in females, usually in patients over about the age of 50, generally solitary, a reddish or pinkish nodule like this. I mean, it looks a bit like, what does it look like? A pyogenic granuloma. Perhaps an amelanotic melanoma would look like this. Smooth surfaced, usually on head and neck. And malignant change is really very rare in this sort of nodular hidradenoma. And let's see if we can get some pathology on this, on a nodular hidradenoma. Let's see if they've got one here. No, just go back up here. There we go, nodular hidradenoma. Okay, they're describing it of solid areas with several types of pale cells, sometimes clear and dark, eosinophilic cytoplasm. Cystic areas may contain eosinophilic amorphous material. Tubes are lined by cubic or cylindric epithelium. Let's have a look here anyway. Okay, again, plenty of ducts telling you that it's probably an eccrine tumor. A lot of blue cells again, well encapsulated. Mixture of pale cells and dark cells. Yeah, it's like the inside of a lymph node with a center on the mantle. So they're saying solid areas contain several kinds of cells: pale, sometimes clear cells, and dark, sometimes squamoid or mucinous cells are present. Cystic areas have eosinophilic amorphous material, fair enough. Lining's flat. Mitotic activity is present even in benign tumors. And the diagnostic criteria for something being malignant is cellular polymorphism and invasive growth. Okay. Well, I mean, this looks very well encapsulated. Just the two different types of cells, clear and the dark, the eosinophilic material, the multiple ducts, and cuboidal cell lining. So, a nodular hidradenoma. And as we say, that was that solitary lesion that we saw in the scalp here, a nodular hidradenoma. What were the other ones I wanted to show you? We have this one here. Now, this was an eccrine poroma. You've got a lot of sweat glands, the palms of the hands and the soles of the feet. So this is where you'll often see this lesion, pinkish or skin-colored, palms of the hands or the soles of the feet. It's again a benign tumor. It's mainly, again, in adults, there's again a smooth red or pink lesion or nodule, acrocytes. Occasionally you'll get surface erosion, more likely perhaps in the feet. Not likely to be painful, as against the spiradenoma, which was painful. You can get multiple lesions, although I must admit I tend to have only seen it as single lesions. And very rarely it can change into a porocarcinoma. We've got another example here of an eccrine poroma. This one was on the toes, I think, here. Again, skin-colored. This was the dermatoscopy of this lesion. Looped vessels. I don't know that it can tell you much more. You can get looped vessels in any rapidly growing lesion. They're not really surrounded by a lot of keratin, so it's not likely to be a sebaceous or squamous type carcinoma. So looped vessels may be a feature of, you can see them there, maybe a feature of an eccrine poroma. Let's have a little look at the histopathology of this. See if we can get an eccrine poroma. There we go. Eccrine poroma. They're saying soles in 2/3 of cases. You know, hands and fingers. We just showed you that fingers one. Can get quite big, usually solitary, but up to 2 centimeters in diameter. Located within the dermis, communicates with the epidermis by broad bands of tumorous epithelium. Cells are basaloid, roundish, regular, paler than normal keratinocytes. Small ducts, small foci of keratinization. Let's have a look. See this one here. Okay, so it is fairly well differentiated. It certainly is intraepidermal, isn't it? And it's very well demarcated. You know, there's your normal epidermis here, and then suddenly, boom, you get this thing here. And you can see how it's sitting up on the surface like this. This one looks as if it'd be almost on the rufous surface, whereas the one we were showing you there just now was very smooth surfaced. Let's just bring that down a bit. Again, clearer cells and darker cells. Not as much duct formation in this. They're saying duct formation in this eccrine poroma is in fact quite rare. There's another one called a dermal duct tumor, which is a wholly dermal variant of this. You can get sebaceous differentiation in the apocrine variant. Prominent vascularity of the associated stroma. Well, they do look very pink clinically. Let's just go into this a little bit more. Variation in the cells there. Well-defined border. You can see how most of it is intraepidermal. No ducts within this tumor either. I think they sometimes call this a hydroacanthoma simplex. You can well see how they would, acanthomatosis in the epidermis, thickening of the epidermis itself. You might think it's a type of seborrheic keratosis. It's so intraepidermal. But this is an eccrine poroma. What else did we have? Just one last tumor I wanted to look at with you, and it's this one, and it's an important one. A nose, a cheek, small lesions, look like little cysts here. This area felt very firm, and it extended all the way out here. And this is a uncommon condition. It's not one that we'll see a lot of. And it's called a microcystic adnexal carcinoma, MAC, microcystic adnexal carcinoma. And it's a low-grade malignant proliferation of sweat duct lesions, and sometimes there's a little bit of follicular differentiation as well. But the problem with it is there's a thick stromal reaction, and strands of cells go in a sort of desmoplastic fashion and extend out much further than you think, and they'll have a propensity to go along nerves as well. And though it's a benign lesion, it can spread well beyond the obvious confines of the tumor itself, and can ultimately cause serious problems. These are some pictures of a microcystic adnexal carcinoma that we had here. You can see the extent of the stromal reaction down here. You can see these strands of cells in between. There is eccrine differentiation here as well. So is it a desmoplastic Syringoma that you're looking at? This tumor particularly occurs in younger people, younger to middle-aged adults. It can occur even in young children, and you usually have this skin-colored plaque, just as I showed you there before. Very rarely do you ever get ulceration. And it's usually in that cheek or nasolabial area that you're going to see it. If it does involve nerves, then you can start to get paresthesia and sometimes a bit of numbness as well. Surgical excision is often inadequate in these, as you can see just from the infiltrating nature of this. Getting the margin is going to be difficult, and so doing this by Mohs surgery is going to be a much better way of treating this than simple excision. If you're going to do it, do a delayed closure. systemic spread of this is really very, very rare, and occasionally this microcystic adnexal carcinoma could spread to local lymph nodes. What other pictures have we got here? This one, by the way, can go all the way down to the fat and subcutaneous tissue here, and even involve skeletal muscle. You can see that there appears to be very little association or contact with the overlying epidermis. Let's see if we can go in a little bit closer to this. These are the ducts here. You can see these strands in between the eosinophilic stroma here. Not sure if we can see any spread around the nerve. Not obvious to me. There can be a bit of inflammatory reaction. There are obviously some lymphocytes and the like here, but there's not a lot of lymphocytic involvement in this part down here. It's usually fairly mild. There's no, just mild cytological atypia. Let's just go into this. You can see that picture. You see the stromal reaction here. I mean, a desmoplastic Syringoma, to my mind, would look very similar to this. And even the desmoplastic trichoepithelioma will look similar, although there won't be as many ducts as you'll get in the desmoplastic Syringoma. And remember, again, it obviously looks like an infiltrating BCC. That's usually part of your differential diagnosis. Very rarely you can get metastatic disease, particularly breast metastases, that will give you that single file or indial file arrangement of cells in a desmoplastic stroma as well. They're your main differentials that you have to consider. This was just another picture here. Let's see if they've got anything in the atlas on this one. Microcystic adnexal carcinoma, here we go. They're saying large, deeply infiltrating tumor consisting of epithelial nest, ducts, glandular structures, sometimes focal hair follicle differentiation. That's when it'll look like a trichoepithelioma. Rare mitoses. Perineural spread is sometimes present. Some authors sort of say that it's almost invariably present. Let's have a little look at their example here. What have we got? Should have a stroma, should have strands of cells. Got a few ducts here as well. This helps actually in making the diagnosis when you've got the ducts here. But again, these strands of cells in between the stroma. Let's have a look at another one. What have they got? Let's look at this one here. Here you can see how deep it's going. It's going deeply into the fat tissue here. Multiple ducts here, thin strands of cells, thick stroma. Just go a little bit closer into this one. See if we can move it around a bit. Yeah, I think it's the depth of invasion of this one that would get you concerned. But as I say, desmoplastic Syringoma would have difficulty differentiating this from it. Occasionally you can get a clear cell change in some of these as well, and occasionally sometimes sebaceous and apocrine differentiation as well. Okay, I don't think I'll be able to get much more out of that. Let's just have a look again at the clinicals. So, microcystic adnexal carcinoma. Watch this one. Thick plaque, usually on the face. It may have some follicular differentiation, may have sebaceous differentiation. It's going to be a difficult one to diagnose. They'll probably have to do a variety of special stains. And remember, these are other tumors that can present with pathology, like with infiltration like that, like the metastatic breast, like the desmoplastic basal cell carcinoma, or the infiltrating basal cell carcinoma as well, because it's all part of the differential diagnosis of this tumor. So, sweat gland tumors, an interesting group. And I think if we can go back to our original website here, have we done all of them? Microcystic adnexal carcinoma, Eccrine poroma we looked like, the Chondroid Syringoma, ordinary Syringomas, the spiradenoma, and the Cylindroma. Yep, we've had a look at all of them. Thanks very much.